So in the second part of week 7, it's really important that we understand not only independent and dependent variables and what their level of measurement is based on their response choices, but we need to understand these two kind of twin or paired concepts. One is reliability and the other is validity. And the reason why we look at experimental designs and we talk about them as the gold standard is because they help us really cover both these concepts. So I'll give you some examples. We'll go through some terminology and then we'll tie it together with how reliability and validity work really well in a true experimental design. So as we begin, we need to understand what they mean. A lot of people blur them or switch them. And if we think about reliability, it means repeatability. It means if you do the same survey, the same test, the same assessment within a short amount of time, no matter who does the assessment, you should get the same results within a very tight range of scores, right? If I'm assessing somebody and I say that they are not depressed and you assess them using the same measurement and say they are depressed, there's a problem with either the measurement or the instructions on how to use that assessment. So reliability means if we all do the same test, the same assessment, or if we do the same intervention with similar groups, we should get the same results or similar results. Now, validity is a little bit deeper. So validity, we need to take a step back and it says like, are you really measuring the full concept that you're intending to measure? So if you're really looking at cognitive assessment and all of the questions you're asking people are about mobility, you don't have validity, right? You may have reliability where people score the same no matter who gives them that assessment, but the underlying part of your assessment should be about cognitive ability, but you're asking people about mobility or something different. So you have to make sure that the measurement, the test, whatever you're using, that it is valid first. And then if it's valid and you're asking questions that are properly constructed, no matter who asks those questions, the test should be reliable. And I'll break it down. Right? Reliability, again, repeatability, no matter who gives that survey, no matter who assesses that person, patient, functional ability, mental status, however you're assessing the person, it should be the same, right? So if I'm testing someone and I say that their functional independence measure, let's say is 10, and somebody else says they're 20, we have to look into it and say, what's going on here? Are we assessing the same way? Are we using the same questions? How are we coding and scoring, right? Reliability means it's repeatable. There's a reliability coefficient. Right now, don't worry about the coefficient. Just know that 1 means perfect reliability, that when you repeat this measure, this survey, this test, whatever you're doing, the higher you are to 1, the better it is. So if somebody says, you know, this depression scale has a reliability indicator of 0.95, that's good. Right. If they say it's 0.1, that would be excellent. I mean, it's 1.0, but that rarely happens, right? So the higher the coefficient, the more reliability, the more times that this test can be repeated and come up with the same results. And I want you to think, right, that certain things are easier to have repeatability with. So we have standard measures to capture various heart conditions, right? So let's say an EKG, right? Or let's say some stress testing. So we have these tests, we outline the parameters, and we know how to give them, we know the instructions, and we know what the scores mean. So for cardiologists who are assessing someone using an EKG and using stress tests, will make the same diagnosis of arrhythmia, right? Irregular or change in heartbeat or heart rhythm. And let's look at it about psychiatrists, right? So psychological distress, if we don't have something that's in the DSM, right, the Diagnostic and Statistical Manual for mental health issues, let's say we don't have psychological distress, and we make an assessment, But because maybe it's a little bit more ambiguous, maybe we didn't define the terms properly, the psychiatrists may have more difficulty or more variation, right, in coming up with a diagnosis. Thus, we have things like the DSM and other statistical manuals that help people code. If you have these symptoms plus this symptom, then you have this outcome or this condition, right? So you have to think that tests that are really structured, really with clear instructions, survey questions that are really non-ambiguous, they are the most reliable. And then it's like a general word and then really giving specific categories or terms. There are many types of reliability. And the first one is like test retest reliability or stability. And it basically says that if you do an assessment now, right, and then 5 minutes later you do the same assessment, they should be close, right? So I used to do a functional assessment measure for people post-hip fracture. So if I assess the person now and I assess them in 10 minutes, the score should be the same, if not very close. But let's say they were given anesthesia or given medication in the interim between the tests, that's something unusual. So that will affect reliability because the conditions of the test have changed. So if the conditions are stable, you test a person, and then a few minutes later you conduct that same test, you should have the same or very, very, very similar results. Inter-rater reliability means, let's say you and I are both working on this study, which happened a lot. So I was the project manager and we had a study nurse who was in charge of all the clinical testing and all of the consenting of patients to enroll in the study. So when she and I would assess somebody's, cognitive ability, we have to have a similar outcome. Again, if she's saying this person is cognitively impaired and I'm saying they're not, that's not reliable. So do two people make the same assessment? Do two people make the same diagnosis, right? We have to think about how consistent two people are evaluating the same person, right? And then this is really, really, really important. Internal consistency, reliability, right? It's a hugely packed phrase, but it means that if you're testing a concept, do you have enough about that concept? So let's think back to depression. So depression has many like behavioral patterns with it, many emotional patterns, right? So in a depression measure, you have to ask about all these things. So you may want to ask about mood, right? Have you experienced a change in mood? You may want to ask about sleep, which is another impact or another item related to depression. Have you noticed changes in your sleep pattern, behaviors? Are you isolating more? Do you find yourself wanting to be alone or crying? Social, right? Do you find yourself withdrawing from activities that you once found meaningful? So if in depression, we only ask about mood or sleep or social changes, it's incomplete. Internal consistency reliability means, have you asked questions about every kind of concept or any kind of item or thought that can be related to this concept? And then validity is the flip, but validity really, if you think about it, needs to come first, right? Are you measuring what you think you're measuring? You can get the same score over and over again on an outcome measure, but is that really measuring what you want to measure? And I'll give you an example. We used to do a cognitive screen, right, to get someone's cognitive status to see if they had any kind of memory issues, right, when we were doing surveys. But we found out a lot of the people we were working with, they were not, they didn't have like dementia, they didn't have a cognitive impairment, they had some delirium. So they were coming off of anesthesia, and delirium is a different mental state than depression. Depression, dementia, delirium, the 3Ds, people switch them, people have them together. But we were using a screen for dementia when our people were experiencing delirium. So our depression measure had no validity because it didn't capture the cognitive and the changes that our population were experiencing. They were experiencing delirium, right? Post-anesthesia, post-medication-based delirium. So, right, testing people for dementia when we really should have been testing for delirium meant that we had no validity in terms of using that depression measure, right? And we'll talk about all these types, right? Internal, external, each of these phrases applies to a type of validity. But basically, you want to look at it and say, can we be assured that in this study, the independent variable precedes the dependent, causes the dependent? Are there any kind of theories that we can use to make this relationship happen? Like, why do we think people who are depressed won't complete this program, right? Think back to the last slide. And then for validity, you want to think like, is there greater validity, or are these conditions only appropriate for patients in my practice or people in my hospital, or, providers post-COVID in Baltimore County, right? You want to make sure that your study has good internal validity, but you can then apply it to others, which is external validity, right? So we'll go through these one by one. But again, think about it. Are you measuring what you really want to measure? Is the test you're doing, is the measure, is the survey, is the assessment really getting at the heart of what you want? And that statistical conclusion validity, it just means, and think about this for later, that the sample that you're choosing can be sufficient to predict the results. That's all you have to think about. Does the sample you have, is there enough people in that sample? Does it have enough power to actually let statistical testing happen? And that's statistical validity, that the sample is solid enough that it can withstand or be used to do some statistical testing. But here's the real ones, right? Here's the kind of real, the nitty-gritty of validity. And I want you to think this particular type of validity here, this is so much why we use experiments if we can. Quasi-experimental design, right? A natural experiment, all these kind of things are really important because they make internal validity work. Internal validity says you can predict the relationship to which the independent causes the change in the dependent, and it's not an extraneous or other variable, right? Remember the idea that people's depression, independent, predicted their outcome in that program, dependent, but there was extraneous variables of gender, right? So what you're doing in internal validity is you're guaranteeing that the relationships you're setting out between the independent variable, the dependent variable, and those extraneous variables, that you're plotting it out and that relationship in time is correct. So internal validity means you're getting the timing and the ordering of variables right. Right, so that's your first type, right? Can I be assured that the independent and dependent variables are related? Independent comes first, dependent comes second, and then I'm accounting for those extraneous or other variables. They're also called spurious. So if I say spurious, think of spuriousness and extraneous variables. They're the same thing. And then construct validity is usually based on theory, right? So it's like, how are you defining a variable? Did you get every aspect of the variable? So think about construct validity, and I'll give you an example of my measure. I'm looking at the way that person and place work together. So I'm looking at how the place somebody lives suits them. So the way that I have construct validity is I read the literature about what aspects of place are important to older people. And then I made scales or questions that get at resources, personal attachment to people, whether people feel valued in their neighborhood, whether people like their neighbors, right? Whether people feel that the neighborhood's a good place for older people. So all of these items, all of these ideas, all define the main concept of, does the place fit the person, place, fit? Because they're all wrapped up in how a person assesses, like, does this place suit my needs, right? So are you looking at everything, right? if you're overly simplifying something and you're looking at quality of life and you're only looking at like blood testing or some clinical assessments without any older adult or anybody's self-rated assessment, it's pretty flat, right? Construct validity says, look at the literature, look at the theories, see what they say about quality of life, well-being, person, place, fit, whatever you're looking at, and make sure that you're capturing all of those concepts. And this is think about generalizability. Generalizability, you're taking your sample and you're taking what you find and you're generalizing it, or you're extending it or referring it back to a larger population. So here's what I found in my study. Here's how it relates to other groups that are similar. That's what external validity is. Right? You want to relate. It's great that things worked in your study. Let's say you test a medication that works against some form of cancer. So it's wonderful that you've done it within your study conditions, right? But can you relate that to a larger population? So can you relate it and say that, you know, this drug will also work for people with this stage of cancer, these comorbidities, and this and this and this? You want to generalize it out, and that's the goal. Right. So let's say you did a study about social determinants of health in Baltimore County. Can you generalize it to Maryland, to the US, right? How can you extend that study without overreaching, right? You have to make sure that the population you're generalizing back to resemble the sample that you tested. Right? Think about that. So internal validity is the structure or kind of the completeness of your study. And then external validity is, can you then take your results and findings and expand them or generalize them out to other groups, right? Think of the population groups. And this is why this double-blind controlled experimental study is the gold standard, right? It does everything. It allows you to decide what is the independent variable. You are manipulating the independent variable. You're giving someone treatment or not. You're giving someone placebo or not. You're doing that. And at the end, you're looking at the outcome, right? So you know the temporal order and you are the one kind of designing it. So you control in an experiment all those extraneous variables. So anything that could influence the participants, you try to control. Right? So how do you do it? Of course, we have steps. Right? The first thing you need to do is really think about the intervention. Think about the controls that you will use. Think about how you will assign people to exposure groups, right? Are you going to do random assignment? What's your goal there? And then what's the endpoint that's a good outcome? So what's your dependent variable and how will you measure it? And you have to think, like, you know, depending on the study and depending on the treatment and depending on the severity. Think of the sepsis study. There were people in that study who were in septic shock, right? How do you just decide, and how do you assign participants to the exposure and the control group? Right? So all things you need to consider. So let's take this step by step. So what is an intervention? It's a strategic action that wants to improve health of a population or individual, right? So what's the intervention? Is the intervention a 6-week course about a falls prevention? Is it a 6-week course or 10-week course about stress reduction for practitioners or care providers? Is it, you know, an exercise treatment, you know, an exercise protocol? And then member eligibility in terms of exclusion and inclusion criteria. Who's eligible? Who will you exclude? Maybe people who have had a prior health condition, or maybe people who you decide you don't want to include practitioners who have had COVID in your study because you think that will introduce more stress, right? That's up to you as a researcher. And then how will you administer the training? So are you going to do, if you're doing something to reduce stress for practitioners, are you going to make them come to meetings, you know, 6 a.m. on a Friday? Probably not. You may want to do, as we did with the caregivers, we did a virtual CDC-based virtual caregiver like virtual kind of tech skills for caregivers, funded by CDC Foundation. And we did it online because caregivers are providing care. Caregivers did not have time in our group to take this training, AKA the intervention, while they're also caring for somebody, in our case, who had Alzheimer's and or dementia, or related dementia. So you have to think, how will you administer this intervention in a way that's going to really keep people in? It's going to maintain people in your study. You don't want people to leave your study. You don't want attrition, right? You want to keep people in. You want to keep them responding. So think about, right? How long, how will I do this intervention, and what's feasible and what's reasonable for the group? And now let's say you have the group that you want to administer an intervention. So I know the group I want to, kind of test, but you also have to go the reverse way and say, now, who's the control group, right? Usually a control group is a pre-existing group, and you do not administer your intervention, right? So the traditional one is that they get a placebo, right? So somebody's getting a medication, somebody's getting the sugar pill, right? You can also do it, if you think about it, let's say that you have a new exercise protocol that really will help with balance. And this is a wonderful, wonderful protocol. So does that mean that you do nothing with the other people? No, you give them this normal standard of care, traditional standard of care. So you use this as your control. So typical standard of care is my control, my experimental or my new program is my experimental group. And then sometimes people are very fancy and they're like, okay, I want to try a lot of interventions at once. It makes it sometimes a little bit more messy with analysis, but you can do regular standard of care, protocol 1, protocol 2, protocol 3, and then see which works. And I was involved in one for exercise testing it was a treadmill with metabolic rate. And they ran different protocols while you're on the treadmill. And then they would test and look at some biological data, right? Some metabolic data based on each of these protocols. So they didn't just have one protocol, they had about 4. And we know, because after that test, it was just, it was pretty rough, but that was the way they designed their study. So what is the placebo? What is normal, like standard of care? And then what's going to be your experimental protocol? And again, right, this idea that nothing is perfect. We declare limitations in every study, and that's completely fine. There's no problem. We all have limits in our work because no study is done perfectly. But you want to make sure that this is not happening. So Hawthorne effect, it's like, okay, I know that I'm being observed, so therefore I'm going to perform better. And there's this really cool example that, right, you're looking at people and you're telling them to do a food diary, right? So write down everything you eat from morning till night, every day for a week. And all of a sudden, each day you see the food gets better, and they start to eat more vegetables, and they're starting to, have better food choices and less processed food. And you have to think to yourself, is what's going on? Is the change you see really that the people are eating better? Or could it be they're recording better food because they know that you're reading their food diary, right? How do you really assess behavioral change or the social desirability, right? This is Hawthorne effect. So we have to be mindful. Now, the step about assigning participants, remember the double-blind randomized control trial, we love that, right? That's the pinnacle of stuff, but it's really not feasible for all studies. So you have to think, who knows what? How do we reduce bias? So if we single blind a study, it means participants don't know if they're in the control or experimental, right? Active or control. But if we double blind, it means that I, as the researcher, when I'm interacting with the participants, I don't know. Because I may know, which may influence the way that I engage with that participant, right? We're human beings, we may do that. So sometimes in research, you might have somebody outside of the study do the randomization and assign people to groups. And so you yourself won't know, and the participants won't know. Because if you do know, right, if you're only single blind and we're the observer, we're the researcher, we might evaluate people differently. I may see that that experimental group is doing really well. You know, I may look at it through a different lens, or I may see that the control group is doing poorly. So knowing what group someone's in might really unconsciously or consciously influence the way that you evaluate them. So it's great if you don't know, if you can have someone else assign people to groups, and then you really, when you're interacting with participants, you won't know. And again, randomization and generalizability, they go hand in glove. They're, you know, they're best friends, right? They're frenemies, but they're actually really friends. We need to randomize if we can, right? Sometimes we cannot do random assignment, right? We can't assure that people have an equal chance of getting assigned to both groups. If we say an experiment is quasi-experimental, it means that what? That people were assigned to the control and to the experimental group without random selection. So perhaps they said, okay, you know, we need, I don't know, 50 men or 50 women or whatever the quota was. They might have had that. Or they might have just said, okay, the first 20 people who, you know, sign up for the study and meet the eligibility criteria we're going to take. So there's no random assignment from like a list or a sampling frame. They're just getting people in the study. And it's okay, but we have to note it. And sometimes we have natural experiments where, let's say that you and I have again, I'm just stuck on this functional assessment, but we have a you know, PT or an OT practice. And I'm using the traditional method, and you decide to use a new method. So we have patients that are pretty similar, right, in their characteristics, except it just so happens that you begin using this new method and I'm still using a traditional method. We can compare the outcome of those groups, but it's a natural experiment because it sort of happened. We didn't plan it, but it's something that allows us to do comparison. And then assignment of participants, right? Who gets what? And this is like, in research, it's really, really something we have to think about very carefully, because the people who get in a group that receive treatment really may benefit unless the treatment has some harmful side effects. So which group are people assigned to? If it's a controlled trial, some people are going to be intervention, some are going to be non-active or comparison group. If it's the randomized control trial, some get the intervention, some get the control, and they're all followed. If it's a before and after study, pre or post test, think of an intervention like the exercise protocol. So we're going to do an exercise protocol, or we're going to do like 6 weeks of stress reduction with workers who worked through COVID, healthcare workers or professional practitioners who worked through COVID. So we can do a pre-test. So what's your level of stress or anxiety before our training or before our intervention? And then after, we do the post-test. We compare. So for each overall, did the level of stress go down for the whole group after this training? And then for individuals, what was the percent change? We would hope that people's stress would be reduced both overall as a group, but also individuals, we would see a decline or a decrease in stress, right? So we can test that way. And then you want to define outcomes, right? What are you looking for? Are you looking for a trial, a clinical trial that does superiority, which says that your new intervention is better? It's like hypothesis testing, no difference or directional difference. So are you wanting to say your new measure is better? Equivalence says, well, my measure is just as good, right? My protocol is just as good. And then non-inferiority says, well, you know, it's not worse, right? So think about what you're testing. I would think you want to test that your new measure is at least equivalent or superior. Saying it, you know, it does no worse than the existing one might be a way to start, but eventually you want to say that your new measure or your new trial or your new protocol is going to be better, right? That's the goal. And then just like the IRB, just like, engaging participants, we have to think that experiments, because we're doing a lot of control, we're doing a lot of assignment, we have also some ethical protocols. Equipoise says that if you don't know, you can only do experimental work if you're not sure that one treatment is better. If you know a treatment is better and it's quote unquote proven, then it's not really fair, because then you are inflating or giving people disadvantage by not giving them that treatment. Distributive justice says, right, that if you are testing this on people who are poor, right, but they never see the benefit, it's got to be justice, right, for all, so that everyone in the population can benefit from this intervention. And respect for people, right, that people understand, think of IRB consent, they understand what are the potential risks of this study, and that people are monitored so that when they leave the study, we can understand if there's any adverse event, and that there's some protocol for treatment. So if people get hurt during this intervention, or there's some outcome that's negative, we address it. And then beneficence and non-maleficence, right? As I always say, that there has to be some idea that we believe there's some good, and that the good of this study outweighs the benefits, and the good outweigh the harm, right? That we're not just doing it to do it, that if the things that we think hold true, when we find the results that we're studying or questioning, that there are true benefits to this, and it outweighs whatever we ask participants to do within the experiment. And then now we're going to talk a little bit about diagnostic accuracy. So I'm going to give you a second, because this slide is a bit packed, but I think as practitioners, you might use these concepts quite often. So diagnostic accuracy really says that you are predicting, or you're getting the correct information. So when you get a positive on a test, it's a positive, a true positive. And when you get a negative on a test, true positive and true negative, these are real. These two are the problems, right? So sensitivity or true positive, I'm sorry, these are what you want, right? So sensitivity or true positive is people who have the test and test positive. So, right, I have, let's say, HIV, when I did HIV screening, so we know that the test has high sensitivity, which means it's going to tell you that it picks up positives. And we wanted a test with high sensitivity because HIV is an infectious disease. So we want to make sure that that test is really sensitive, delicate, quick, and accurate, and will pick up a positive. If we look at specificity, the true negative rate, it's the portion of people who do not have the disease who test negative. And while we were interested in specificity, so people who are negative were negative, we were more concerned with sensitivity. If that virus was present, we want to make sure the test will pick it up. High sensitivity, right? If you think about the reverse, let's look at a false positive. A false positive, you're telling someone you have HIV. According to this test, in the antibody testing, you have HIV, right? But it's a false positive because they're actually negative. So something in the test went wrong, and now you're telling someone they have a disease, which they do not, or have a screening test positive, which they don't. In this case, whenever we would get a positive, the practice in our clinic was to redo it, because we wanted to make sure that if we got a positive, it was a true positive based on sensitivity, and that we did not get a false positive. We would also do some PCR or higher level testing. And you can see the analogy to COVID, right? So true positives are great. It's sensitivity, your test is accurate. False positives are rough because you have a positive result, but you don't know if it's real. There's maybe some issue with the test, so you repeat the test. We want true negatives, right? If someone doesn't have a condition, we know it, but think about a false negative. A false negative says, I tell someone you're HIV negative according to this test that we've done that looks at antibodies, right? Meanwhile, they're HIV positive. Think about the ramifications in healthcare. If you tell someone you are HIV negative, right? But it's a false negative. They are really positive. Then they go out saying, okay, I'm HIV negative. I don't have to worry about, let's say, using precautions, right, during sex, or I don't have to like worry when if I use intravenous drugs or share needles or whatever the issue is. That person who is really positive is told they're negative, right? So think about what this means, right? You want to make sure true positives come in positive. You want to think about false positives. Tell someone they have a disease when they don't, and there's the emotional stress and strain. But think about a false negative. Somebody is positive for a disease or condition, and you're telling them they don't have it. So this denies them treatment. This also spreads disease if it's a contagious disease. So think about all of these various combinations. And I know you may use this in your practice, but we want a test generally that has high sensitivity, right? High sensitivity. Really be able to tell me that when I get a positive, I want it to be this. I want all my positives to be true, right? That's my test. And maybe it's costly to construct tests this way. Maybe it takes more technology, but we really want to think about what each of these squares mean when we give the results to people. So I went through this kind of quick, but take some time. I know you have your books and you have the notes. I'm going to end this video, and then I'm going to briefly go over what your article critique paper will be in the next one. So I'll catch up with you soon.